Welcome to our session on trauma. First, we have Dr. Haleema. She is the Associate Professor from Assisi Medical College. She will talk about how to evaluate and classify ocular trauma.
Good morning, all. Today, I am going to deal with ocular trauma, its classification and evaluation. Ocular trauma is more common among younger age group and the elderly above 70 years. And the major contributors of ocular trauma are road traffic accidents. Regarding the classification, in 1996, Kun et al. Introduced a classification system for eye trauma, which is called the Birmingham Eye Trauma Terminology System. In this classification system, mechanical eye injuries are classified into closed globe injuries and open globe injuries. Closed globe injuries again classified into contusion and lamellar laceration. In contusion, there won't be any eye wall injury, but there will be structural damage inside. In lamellar laceration, there will be a partial thickness eye wall injury. Open globe injuries are again classified into laceration and rupture. Rupture means it's a full thickness eye wall injury, but because of a blunt trauma. Laceration again classified into penetrating injury, in which there will be a single wound, intraocular foreign body, and perforating foreign body. Perforating injury means there will be an entrance and exit wounds. International Ocular Trauma Classification, a classification system of mechanical injuries based on bed and features of globe injury at the time of presentation. And this system categorizes trauma by 4 parameters. Type means the mechanism of injury, grade based on initial visual acuity, presence or absence of RAPD, extent or zone of injury. This is widely used for recording purpose, and the types of open globe injury are rupture, penetrating, intraocular foreign body, perforating, and mixed. And these are recorded as A2, A, B, C, D, or E. And the visual acuity is graded in between 20/40 to no PL. And pupil is recorded as positive if RAPD is present and negative if RAPD is absent. And the zones are zone 1, limited to cornea up to the corneoscleral limbus. Then zone 2 means from the limbus to 5 mm posterior into the sclera. Zone 3, posterior to that 5 mm of anterior sclera. Closed globe injury types are contusion, lamellar laceration, superficial foreign body, and mixed type. Visual acuity grading and pupil is same as that of open globe injury. And the zones are, zone 1 is external, limited to conjunctiva, cornea, and sclera. Zone 2, anterior segment up to the posterior lens capsule. Zone 3 is posterior segment behind the posterior lens capsule. Ocular trauma score is again proposed by Kun et al., and this provides a simple system with few variables to predict final visual outcome of an injured eye. In this, initial visual acuity, globe rupture, endophthalmitis, perforating injury, retinal detachment, and RAPD are considered. There are certain disadvantages of Budd's classification, in which adnexal injuries, destructive globe injuries, and non-mechanical injuries are not considered. So the classification system proposed by Dr. Shukla in 2017 is approved by the Ocular Trauma Society of India, is a comprehensive classification. In this classification, along with the mechanical injuries, non-mechanical injuries are also considered. Ocular trauma associated with the other traumas are also considered, and different causes of ocular trauma are classified under environmental classification. Again, mechanical injuries are classified into adnexal and global injuries. Global injuries, again, classified into structural and pathological. Under pathological classification, along with closed globe and open globe injuries, destructive globe injuries are also considered. Now, how to approach a patient with ocular trauma? Before any history or examination, don't forget to make sure that the patient is systemically stable, and immediate attention should be given to chemical injuries, in which an immediate eye wash is important to remove the chemical particles. Then rule out open globe injuries so that your further examination will be careful. Now coming to a focused history, to know the mechanism of injury, whether it is blunt or sharp, metallic or vegetative, then symptoms like vision loss, diplopia, previous ocular history like surgeries, contact lens usage, eye trauma, prior poor vision. Then in case of injuries by animals, need of anti-rabies vaccination should be kept in mind. Then a detailed ophthalmic evaluation, which includes best-corrected visual acuity, pupillary examination, ocular movements, slit lamp examination, and ophthalmoscopic evaluation. Then don't forget to do a proper documentation and medico-legal registration if required. In orbit, look for crepitus, infraorbital anesthesia, enophthalmos, proptosis. Ocular movements may be restricted in case of muscle entrapment or cranial nerve injury. Then look for lid tears, canancular injuries, canthal tears. In conjunctiva, rule out foreign bodies and retain chemical particles. Cornea, look for any full thickness or partial thickness wounds. Look for foreign body, high FEMA or reaction in AD3 chamber. Rule out iridodialysis, sphincter tears. Look for any subluxation, dislocation, or cataract in lens. Rule out commotio retina, retinal tears, and or choroidal rupture or retinal foreign body. And in optic nerve, rule out optic neuropathy, optic nerve avulsion, hemorrhages. IOP can be deferred in case of open globe injury. And if possible, you can do a photography also. Regarding investigations, CT scan, both coronal and axial views are taken in case of suspected intraocular foreign body or intraorbital foreign body, or if you suspect orbital fractures. If CTs are not available, go for X-ray. Ultrasound B scan for posterior segment evaluation in closed globe injuries. In open globe injuries, use with extreme caution. MRI has got a very limited role and is contraindicated in patients with the pacemakers or metallic implants. And to conclude, along with the proper history and a detailed evaluation, a proper documentation of all cases of ocular trauma is a must. Thank you.
Thank you.